doctors are doing the best they can wherever they are. Spending more didn't buy you more of the better stuff. Spending more didn't buy you much more of the major elective procedures like bypass surgery or joint replacement. The whole difference across these markets was how much time people spend in the hospital, and there was no gain in life expectancy. We could find no evidence that there was a consistent pattern that places that spent more got better outcomes. In the context of the way American or other health, and I think other systems, healthcare is practiced, where a lot of our decisions are based on what we have available to us as physicians, and it's so much easier to manage someone in the hospital. And there are strong financial interests to keep those beds full.
Yeah.
So people were spending a lot more, and we could have, the estimates that we came up with, and we had a bunch of reviewers, editorials about the work. No, looks like America's wasting 20 to 30% of its spending on unnecessary care.
I'm Judson Howe. I lead hospitals. I've seen a lot of what's broken in healthcare, but we're going to find out ways to make this better. This is Healthcare Reframed. Elliot, you've shaken the very bedrock that Americans think about healthcare largely by showing that more is not always better when it comes to healthcare. Take me to the moment where you started to understand that more clearly, or what led you to that belief?
That's what a fun question. First was the surprise that came when I was a first-year medical student and read an article by Jack Winberg, published in 1973, that showed that in the state of Vermont, physicians gave certain procedures at rates to the people they were taking care of that differed by a factor of 10. You live in one place, you're 10 times as likely to get your prostate taken out as a male, or you're 5 or 6 times as likely to get a hysterectomy. And I was a first-year medical student going to medical school because I was convinced that science was going to give me the answer to how to treat patients. And it really shook my confidence and my classmates' confidence in, well, hold it, what's going on here? How could we disagree so much? Vermont at the time every town was white, every town had a congregational church, every town had a general store. They were identical, so the rates had to be something else. And it took me a long time to get back to join Jack at Dartmouth. But that started the work to try to figure out, if we're spending 2 times as much across small markets like that, what do you get for it? And that was about a 10-year project. And I was lucky to be able to do sort of starting about a third of the way through my career, 10 years after getting to Dartmouth.
I imagine you had a large medical school class, and there's probably thousands of medical students that graduated the same year you did. What made Elliott Fisher uniquely interested in that work?
I grew up, the son of a very famous Harvard professor who had created the field of negotiation, of principled negotiation. He was out solving problems in conflict international law when my brother and I were growing up. And I think both of us were pretty intimidated, but we knew from him and from what my mother did with Planned Parenthood that our job as people was to make the world a better place. Neither of us had a clue about how to do that, right? So you go to college and you're going, what am I going to do with my life? And I really never figured it out in college. I actually did mostly focused on climbing. As I joke, I majored in mountaineering, but that was not a legitimate major in the Ivy League in those years, at Harvard. Yeah. So I majored in Chinese. But when I graduated, I was clueless. I was a climber. I wanted to learn about how to be better in the wilderness, taking care of people if we had an accident. So I got trained as an EMT and drove an ambulance for 1.5 years in Boston, or in Somerville, Mass., which was a mile from where I grew up in fancy Cambridge. And there were children dying of diseases that none of my classmates had. And so I came through that time. I loved the fun of being on the ambulance and thinking you were saving people's lives, because probably mostly their own natural human resilience that people have. But we sometimes got someone to the emergency room in time to be helpful. But I thought, maybe I'll go to medical school. But I knew that part of it was I had to do something about this difference between what I saw in Somerville and what I experienced in Cambridge growing up. I had the best care. I was going to see the famous pediatricians or whatever. But the care in Somerville was awful. I could just tell it. The care that was being delivered was unkind in the emergency room to the poor people who were being treated there, and it wasn't technically very good. Even I could tell it as an EMT. So I went to medical school, and I knew going there that I wanted to become involved in health policy to try to address that, what we'd now call a disparity. All I saw was suffering.
Yeah. You used a word earlier talking about you and your brother were intimidated by your father's success and impact. Give me a story. Paint that picture for me. Give me a moment.
Around this time, he was already getting involved in the Middle East in solving the Middle East dispute. He helped develop the tools that were used at the Camp David to develop the Camp David Accords. When the Harvard undergraduates took over the university in the protests of 1968, he was the one who was called in to, very publicly speak on the media and talk to the students and try to solve the dispute. So, that was casting a long shadow, just in terms of his recognition. He was fighting the Vietnam War for a long time. He helped launch a nonprofit that was devoted to reducing the risk of nuclear war. So we both felt like, oh shoot, we rebelled in our own ways.
Was climbing part of that rebellion?
Yeah, totally.
Teeing back in on where you were going a moment ago, which is the disparity between Cambridge and you said what mile west is Somerville.
Yeah.
Why was there that great of a disparity in a mile? What was driving that disparity?
Poverty. So, in those days, certain parts of Cambridge, the elegant parts where Harvard professors could afford to live in those days, they can't anymore. In those days, parts of Cambridge, were very comfortable, elegant old colonial houses, private schools, shady trees. Somerville was literally less than a mile away. And it was a very poor Boston community, old, but very poor. Now it's become gentrified. But then there was deep poverty there. People, you get to go into people's house as an ambulance driver, as an EMT, and see that there wasn't much food in the fridge, and see just how simply they were living for a young man who'd, yes, I'd been to India by that point and saw that there was poverty, in other places in the globe. But I don't think I'd had the direct, personal, close experience of that, of how people were living essentially in my neighborhood. So medical school, we started doing stuff right at the outset. We started to tell all our classmates that they shouldn't take stethoscopes from the drug companies. We were immediately labeled the granola lunch bunch, and so.
Oh, you shouldn't take any gifts from the drug company.
No.
It was in the 70s.
We were totally opposed to, and we wrote a pamphlet the 13 of us wrote a pamphlet and handed it out to all of our classmates, which was so arrogant. Luckily, 25 years later at our reunions, people were all forgiving and friendly, but we were pretty arrogant about
how was that received by your classmates?
Oh, I said they called us the granola lunch bunch because we lived in Cambridge and walked across the river, and there we were.
You mentioned you work side by side with Jack Wenberg, a name that we rarely hear these days.
Mm-hmm.
Who was he?
So Jack was trained as a nephrologist. He was heading to become a kidney doctor. Hated doing experiments on frogs, to study how the kidney worked, and decided to become an epidemiologist. And then one of the founding fathers of health services research offered him he created the first statewide data set in Vermont, and managed to persuade Vermont to offer Jack the job of running this statewide health systems agency that had the first statewide healthcare claims database. And Jack just said we ought to understand, how healthcare is delivered in each of these communities, how much healthcare people get, what kind of procedures are they getting, and how equally are things distributed. Where is the healthcare going? And he took 3 years with his colleague Alan Goodleson and wrote this article, Variations in Medical Practice, that was published in Science because no American medical journal would take it.
They wouldn't touch it.
No, because it was too controversial. How could it be that doctors are making such incredibly variable decisions? How could it be that there are twofold differences in spending?
Were they doubting the accuracy of the data?
Oh, that's been, of course. People must have been sicker back in this community than that. But that was the work he started to do when he came to Dartmouth, was try to understand what caused the variations. And I got here as he was getting going on that work. And so it was a great time. We had a wonderful experience. We had a small place, lots of good colleagues. Eventually some economists and sociologists joined us, and, but it was a small team, small group of people trying to say, what's going on here?
What was it like to collect data before EMRs in that era?
Oh, well, insurance claims, health insurance claims, especially for Medicare, provided a complete record of what people received from the medical care system. So every procedure, every diagnostic test was recorded in a claim, and you could then start to say, how are people being treated? What are the differences? And that was the early work. The earlier work was saying, do we still see these kinds of variations in rates of specific surgical procedures? And yes, we did. There were huge differences. And were there differences in quality? We noted some, although it's hard to tell. Again, you mentioned EMRs versus the clinical data wasn't completely great, but you could see that there were, 4 or 5-fold differences in mortality rates for common procedures that could not be explained by case mix, had to be about how people were being treated.
So you were confident in your process.
Yeah.
But maybe the industry was incredulous.
Oh, there were lots of people who many people thought it was really important. Some people pushed back and said, you're pushing you don't have the adequate data to address that question. So, that was the 10 years of first 10 years of work, or 15, was every time someone said, you haven't addressed this question yet, you go back, you say, all right, let's address it. Turns out Medicare, I'll talk about one of the studies we did, but turns out the Medicare system had collected chart reviews with detailed clinical data on every patient who had a heart attack in the United States. That's a lot of chart reviews with a lot of detail about the clinical data. So we used that to help us understand, what do you get when you spend more in some places compared to others.
Tell me more about Jack's mind and the way he thought and how that impacted you in your practice of medicine.
Well, I think, applying all what we learned to the 20 years I was practicing in primary care was hard because we were learning, to be skeptical about the quality of the medical evidence, to be uncertain about, if we're not how strong the evidence is, how should we help this particular patient make a decision about it? And I think so it influenced the way many of us, and to be fair and absolutely and critically important, this was a growing group of people around the country by the time we were really going.
Paint that picture for me. So how many people were there in your core group?
And at Dartmouth, there were probably 10 people, but there were people at Mass General, there were people in London, there were people in Norway. I mean, Jack was very good at always, and this is something I probably learned in part from him and part from my father, reach out to people who may disagree with you.
Okay.
And try to understand them, try to hear understand what their perspective is, and then engage them in trying to solve the problem. That was very much what Jack did. The variations in prostate surgery rates, the first thing he did was pull together a bunch of urologists to talk about, what's your theory here?
To kind of unassuming, non-threatening, help me understand
how you guys are making decisions. And
what
they
was
were
the
all
answer?
guys at that point. Well, there were two competing theories. And the urologists were not even aware that they had different theories about why they were operating at that point. One theory was this is because benign prostatic hyperplasia, this enlargement of the prostate gland, tends to be progressive. And then people get older and sicker.
Mm-hmm.
Some urologists thought, well, it'll be safer for people if we operate soon while they have moderate symptoms or mild symptoms. They're healthy now. Why not make their symptoms better? And then and then there were others who said, no. There's no evidence of that will improve people's lives. This should be about helping them pee better.
Yeah.
And they had two completely different competing theories about
what was the right theory?
That's a great question. That Jack should have gotten the Nobel Prize for this answer, right? The short answer is it depends upon what you value. Depends upon what matters to you. The common phrase now, what's important to you, that now should be part of all medical practice. What matters to you is the way you make those decisions. Once you have evidence that there's no life expectancy gain, which they developed, then you're trying to figure out how bothered you are by symptoms and how much the procedure is going to relieve your symptoms. And, there's a slight risk of other side effects, and you need to understand those. So the right choice is the treatment that a well-informed patient would choose once they know the risks, the benefits, the alternatives, and are helped to make that wise decision.
We're here in 2025, and you're talking, what era are we talking here?
We're talking the early 80s.
Help us understand what the physician to patient value connection equation was like back then. How did a physician engage with a patient?
I think, and it's still true, I believe all physicians think they're doing shared decision-making.
Even in the early 80s?
I think, no, that's probably not fair. The mental model, which I think is a really useful word for us all, a term for us all to think about. What's our mental model about what's going on here? That was a little bit of Jack's thinking. It's now widely used in systems thinking. But the mental model that many physicians and patients had is that this is a biological process. Okay. I can treat that biological process. For most people, it'll reverse those symptoms, and therefore I should recommend it to you. And that's and patients' mental model was doctors are experts in biomedicine. I'm not a medical student. I'm not a doctor. I don't understand this. You should tell me what I need. And the work that was, 8 years or so of work by international team trying to figure out what was going on with variations in prostate disease, finally figured out that it really depended upon patients' attitudes towards the different risks and preferences for the different outcomes. And then was able to pretty convincingly show that the actual decisions that were being reached across different physicians were not reflecting patient preferences. They were reflecting physician beliefs. And it's still true now, right? You send a patient with prostate cancer to a radiation therapist. Guess what they recommend?
I'm guessing radiation.
Yeah. You send them to a surgeon. Guess what they recommend?
And so you were seeing this in the early 80s.
It's been true. It's been true for years.
From the beginning of the art.
That particular difference, people, physicians are doing their best with the knowledge sets they have to provide the best possible treatment to their patients, and they believe in what they're doing. And, and the trade-offs between radiation therapy has some complications. Surgical therapy has some complications. And men care about those complications, some of the complications being impotence or incontinence.
Yeah.
With different rates and from different procedures. And it was just this fall that a friend of mine developed prostate cancer. And the first place he went was, I won't say where, but he went there and said, you need surgery. And he was about to get it. Luckily, he talked to my wife and me, and we said, you at least need to get a second opinion. and consider the different possible treatments. And certainly you should find out what the outcomes are by this place that's recommended the surgery. And it was a tiny hospital where, one could, and actually on the national ratings now, quality ratings, it was not a safe place to have a procedure done. So luckily our friend got to a great academic medical center where they helped him make a wise choice. And
what was
the
that choice?
complications were going to be much lower. What?
Did they end up with a procedure?
Yeah, but that doesn't matter what it was. That was his decision aligned with his preferences,
his values,
and understanding all those risks was absolutely critical. So if there's anything to take away from our conversation for patients, is try to get the best possible information about the risks and benefits of the treatment alternatives. And that goes for diagnostic tests. Do I want to be screened for prostate cancer? What are the risks? What are the benefits? How soon do I want to start screening for breast cancer? Get the best information, and then make sure you get whatever treatment is recommended at a place that does a lot of them and is really good, and that you can find, both the best existing data, which there still isn't much. A major gap in American health policy and practice that we don't have great data. But get that data, do your best, get second opinions.
So if I'm hearing you correctly,
choose wisely.
If we can get data, we should go and get it. Isn't there some theories that more data leads to more utilization?
I don't think. I think.
Or reframe that if you need to.
Yeah. So if you have a symptom, you want to understand what might this be, but then you want to be really careful about about understanding the trade-offs of choosing different. Do I want to get a total body scan, a total body CT scan? That'll find, no, we know that our bodies are filled with stuff that looks like cancer on a scan, and turns out to look like cancer under a microscope, but doesn't behave that way. Many of them go away. It's called pseudodisease. So overdiagnosis is a problem. So the best thing you can do is have a great primary care physician. Good luck finding one in these days. We'll get to that when we talk about health policy later. But no, you need to think carefully about whether, and get good advice from a clinician about whether, is this something that I can safely watch? Could easily be better in 3 days.
Right.
One of my favorite diagnostic tools is time. I always taught residents that time is your best diagnostic test.
Expand on that. What does that mean?
If someone comes into the emergency room, yes, you should be worried. Your job is to find the things that could really hurt them.
Okay.
And many things will resolve on their own, and it's just over different time courses. So sometimes, and even if you think they're at high risk and need to be admitted to the hospital, you should check them in a half an hour to make sure they're not, or whatever the right time course is, they're not getting worse. Or if now they're getting a lot better, well, you don't need to come back and see them in 12 hours, or in 2 hours. And for many of the things that people come to the physician for, waiting a week, if it's an achy shoulder that the doctor doesn't think is heart disease.
Yeah.
If your shoulder aches, maybe it's going to go away because you just banged it.
Yeah.
Let's not send you to the orthopedic surgeon today, because I promise you they'll want to do some films.
Let's go back to Jack Wenberg. We're in the early 80s. You said this research of yours is starting to spread. You said internationally, London, Norway, probably beyond, and the United States as well.
Yep.
Where did that research go?
Well, it went after a series of 3 papers in JAMA, to get, the notion of shared decision making became, that problem was the diagnosis. That is, we have a problem of not respecting patients' preferences and values and not having good enough evidence, was recognized. We knew we needed to strengthen the scientific basis of medicine, because a lot of the reason for the variations were we actually didn't know the outcomes of those 2 treatments. So, we didn't know what's the best way to treat a heart attack. Is it bed rest, as people thought for a long time? Well, that turns out to be harmful. Which medication should you use?
If we didn't know what was better, then how did we end up with these different practice patterns?
Because physicians would then adopt different belief patterns for beliefs about what the right
Belief
treatment
sounds
was.
like not data driven.
No, it's opinion driven.
Okay.
Or my own experience driven. And by the way, most people get better. So, the great logical fallacy is after this, therefore because of this, post hoc ergo propter hoc,
Okay.
right? Oh, leeches, they work. Most people get better with or without leeches.
My understanding is that this work evolved into the Dartmouth Atlas.
Mm-hmm.
What was that, and how did we go from research to maybe formalizing and branding this thing something different?
So it was around the time of the Clinton health reform in whatever year it was, 1990, I think. And Jack got RWJ to give us a bunch of money to define the natural markets for healthcare in the United States, where there should be, which is the right, size for competing health insurance plans.
Who's RDBG?
Sorry?
You said RDGB?
No.
You got who to give?
Oh, Robert Wood Johnson Foundation. Got the Robert. Yes, we got the Robert. He got the Robert. So it was around 1990 that the Robert Wood Johnson Foundation gave Jack, multiple millions of dollars to create an atlas of healthcare in the United States, primarily to define the markets where healthcare was delivered, so that was the right size for competing health plans. If we gave everybody insurance, then you would give them a choice of competing health plans. And these are the right size for those markets. Didn't happen to go through. It's still the right answer, right?
Right.
Universal insurance, competing health plans. We can make competition work if we just bothered to try. But in the end, they didn't go forward with it. But we had all this money, and the Robert Wood Johnson Foundation was fine with us starting to replicate what Jack had done in Vermont.
Okay.
For the country as a whole.
So did you have the same quality of data across the
We
nation?
had the Medicare claims data for the whole country.
Did you have
every Medicare beneficiary was in our data set. So practice behaviors, it was the only data we had. It was hard. There was not commercial data at the time that was nationally available, but it let us compare for people age 65 and over, what treatments are they getting and how much did spending differ across markets. And it was replicated what he'd found in Vermont.
Okay.
So huge variations.
Why was it that you and Jack and your teams were finding this? Why wasn't this happening elsewhere in the country?
Well, I think, Jack, we were early to get access to the Medicare claims data.
Okay.
Probably first off the blocks. There's not a huge interest at that point in just documenting variations, and most people sort of forgot about it. That it did. We had a lot of national interest because, we produced the atlas and it was carefully thought through. Jack trying to think about influencing policymakers and how to solve this problem of, what's going on with American healthcare, and using data, from everywhere in the country, to reveal the magnitude of the variations and make them interesting to people. So why should back surgery rates vary by a factor of 8?
Yeah.
Well, if you're facing what's a pretty high risk, expensive procedure, it's worth asking that question. And, this was a time when we thought healthcare was expensive.
How much was it?
I can't remember what percent of GDP it was then. It was probably up to 10 or 11, maybe 12. It was 7% when I started in this business back in the late 70s. Now we're at 18. But people were starting to worry about spending. So that's the piece of the puzzle that I took on, was what about these variations in spending and what do you get for them?
Yeah. So you've been at this for 40 years.
Yeah. I came here in 86.
How effective has your time been at improving these things that you identified in the early 80s?
Oh, if you ask the question, So you were worried about controlling healthcare spending or trying to make sense of healthcare spending.
Yeah.
And you look at the curve of what the growth curve of U.S. healthcare spending, you would not notice any deflection since I arrived on the stage.
In fact, it got worse.
No, I think the rate is actually pretty steadily upward. We can talk about those causes perhaps later, but I think the progress has been understanding what are we getting for all that additional spending, and what are the underlying causes of the differences in spending and quality that happen across the country, and then what are the implications of those for how physicians and other healthcare leaders and hospital leaders should practice, the normative implications of what we learned. And I think we've made real progress on that. I mean, I think it's fair to say that the current, if you're inside the baseball of healthcare, most people will know that value-based care is sort of the thing where people are striving toward to try to improve the value of healthcare. And I think that's in large part, that Jack's work, our work, revealing the variations and then revealing what you get when you spend more across markets and what are the causes of that, contributed substantially to the adoption of the ideas that are now, I think there's now a consensus that this is where we need to go more effectively than we have sort of in our limited way, in our weak way. And we can talk more about why I'm so hopeful that we actually can do better.
Yeah.
Because I think our understanding has advanced a lot. And I think that we're reaching the tipping point of tolerance for the costs that we are now bearing from healthcare.
So we've got this problem, right? We've got this variation in care and outcomes, even in small geographic regions. You mentioned a moment ago about some things we have improved on. And I think you said we've improved on understanding where our dollars are going. That was the number one thing you said.
Yep.
Where are they going now that we understand it better?
So it's really, here we had, twofold, 2+fold, 2.5-fold from the least expensive areas to the most expensive areas, just confirmed in a national study that came out 2 months ago, but showing that the variations in spending are even larger than we had documented, and that they are not due to health status differences. Some of them are.
So normalize that out.
Most of it's not. So what we did was we identified, with another amazingly generous grants from the Johnson Foundation. We tried to identified groups of patients who we could be pretty sure were identical across markets. When you have a hip fracture, you're having the hip fracture because you're frail and old.
Okay.
When you have a heart attack, you're having a heart attack because you've got these risk factors. And so there are higher rates of heart attacks in some places than in other places. But once you've had a heart attack, your risk of death in the next year is pretty similar to people in other areas who've just had their first heart attack. And we also had all sorts of other clinical data because chart reviews have been done on every Medicare patient in our heart attack cohort. And we had a cancer cohort of people. And then we had a representative sample of just the general Medicare population where they survey them every year to see how they're doing. And we were able to identify those people everywhere and then stratify places in the country by how much they were spending on people. And, we did that 2 different ways because the reviewers cared a lot about making sure we were robust in our findings. But what you found was that the patients were, in fact, at the time of their initial hospitalization, nearly identical in terms of their risk of death in the next year.
Okay.
Their risk of death. So we had all sorts of clinical data about them or claims data about their history if they were hip fracture patients. And so they're very similar. And then we followed them over 5 years to see what happened to them. And looked at, did they get over those 5 years? Did they get the treatments that we know are evidence-based? Are they discharged on the right medications? Are they getting, treated for their diabetes? The evidence-based things, are they screened for cancer that we knew were important and could be measured in our data? And there really weren't, there were marked differences in those things, but those weren't associated with differences in spending.
Okay.
Spending more didn't buy you that more of that stuff. And eventually that made sense to us because doctors are doing the best they can wherever they are.
Mm-hmm.
They're doing their best to adhere to the guidelines that are known, and they were getting, so it wasn't more evidence-based practice, and spending more didn't buy you more of the better stuff. Spending more didn't buy you much more of the major elective procedures like bypass surgery or joint replacement. What it bought you was more time in the hospital. So in the higher spending places, and it's still true, patients spend 60% more. We're spending 60% more time in the hospital. They were spending 75% more time in the intensive care unit. Identical patients.
Wow.
And of course, if you're in the hospital and you're seeing lots more physicians and getting lots more diagnostic tests, the whole difference across these markets was how much time people spend in the hospital. And there was no gain in life expectancy, no gain in survival.
Did it get worse?
For the hip fracture patients, it got worse. For the AMI patients, it was borderline worse, but the reviewers wouldn't let us say that.
Okay.
We proved conclusively that it wasn't better. And that's all we needed to do. So, and then we had all sorts of other measures of quality, and then we interviewed physicians to say what they thought about quality in those different markets. We could find no evidence that there was a consistent pattern that places that spent more got better outcomes. In the context of the way American or other health, and I think other systems, healthcare is practiced, where a lot of our decisions are based on what we have available to us as physicians, and it's so much easier to manage someone in the hospital, and there are strong financial interests to keep those beds full.
Yeah.
So people were spending a lot more, and we could have, the estimates that we came up with, and we had a bunch of reviewers, editorials about the work. No, looks like America's wasting 20 to 30% of its spending on unnecessary care.
When you showed this to a policymaker, tell me a story. But you go into a policymaker. How did they react to it?
Well, it was very interesting. It was not long after these. I mean, we had a Republican former Medicare administrator as one of the editorialists.
Remind me the era on this one.
This was going to be 2003.
Okay.
So very kind editorial from Gail Walensky saying this is really important work. Very kind editorial, supportive editorial from a prominent economist, and one by the head of the National Academy of Medicine, all saying this is really important work. It suggests we can do better. So everybody was interested in this, right? I spent time in the Bush White House. I spent time in Congress with Republicans and Democrats.
What were they saying? What did they do with this?
What should we do?
What was the answer?
Well, we got more work to do. It suggested that, it did provide a rationale, and I know this from subsequent conversations with Peter Orzog, for passing universal health insurance.
Bipartisan.
Well,
support.
It wasn't, not really. But the Republicans were, to their credit, very interested in trying to figure out what to do about this, because we couldn't.
Sure.
The Republicans were actually much more concerned about the deficit at that point than the Democrats were.
Yeah.
So there was serious interest in, it was an interesting time, and our work, we quickly followed up our findings from those papers, which took 3 years from when the paper was submitted to when it was finally published, because brutal reviews, a brutal review process led by the current president of Harvard, who became I had 7 reviewers, 8 reviewers, and anyway.
So some rigor.
Thank God for Alan Garber. He got the thing through, and he helped me work to satisfy all the reviewers. But we began working on the next project, which was, given what we know about American healthcare, how can we fix this thing? And that's what led to accountable care organizations over the course of about 5 years.
You're going to have to give us a lot more detail. So how do we go from 2003, this conversation?
No, that's the fun, right?
So
it's a great story. I had so much fun.
Now would be a good time for that story.
Yeah. So the first thing was to try to, really come to grips with what are the underlying causes here. What are the underlying problems of this? First, we learned that capacity was part of it, right? If you have a lot of hospitals, a lot of doctors, you're going to use it all because it's all fee-for-service medicine.
Okay.
Right? Everybody can stay busy. And we interviewed physicians, and the physicians in Miami, the most expensive place in the world, saw their patients once a month on average. Oregon was seeing them every 6 months. People with, basic high blood pressure and no other medical problem.
Miami is the most expensive, or was?
Was then. So
frequent visitation.
So frequent visits, the most expensive decision doctors make is, when should I see you again?
Okay.
If I say a month versus 6 months, it's going to cost much less to see you in 6 months than it will in a month, right?
Mm-hmm.
Everybody was interested in the question. And what we tried to figure out was, well, fee-for-service has several problems. First, leads to fragmented care because no one has any incentive to coordinate care with anybody else.
Okay.
It's sort of it's your obligation as a professional, but it's really hard.
You and I know what fee-for-service is, but what does that mean?
Well, that means, it means that each of us as physicians is only responsible for the visit or condition for which we're seeing the patient. There is no one playing quarterback except in a few rare places like Mayo, the clinic at that point, or Kaiser Permanente, where people would have a primary care physician who really was responsible for their care. And primary care physicians, to their credit, in those days we actually had highly functioning primary care systems in some places, and primary care physicians would be playing quarterback. So care is fragmented, it's not very well coordinated. It's hard for primary care. Unless the specialists really collaborate, it's hard for primary care to do anything. And then there's no accountability. So what we came up with was the question of, is there any way we can replicate integrated delivery systems? Because there were some early models. Mayo was pretty integrated. If you went there, you'd get cared for that way. Kaiser Permanente was group health cooperative with Puget Sound. And the question we asked was, does it probably make sense that physicians work in natural networks around a given hospital?
Okay.
They're all admitting to that hospital. So could we figure out who those physicians were, even if they weren't practicing in the hospital, weren't part of the formal medical staff?
Okay.
So we showed with Medicare data, the claims, that yes, you could assign patients to hospitals and their physicians based on claims data. You could identify the group of physicians, and then you could measure two things: the total cost of care for this population of patients cared for by this network of physicians around a hospital, and you could measure the quality better because you've got much bigger numbers to actually accurately measure quality with the measures that we had. And so we, came up with this idea of, a group of physicians around a hospital, and went and presented the idea to the Medicare Payment Advisory Commission.
Okay.
And we labeled it the Extended Hospital Medical Staff as a way of reforming the payment of healthcare.
Where did we come up? Who coined the term ACO, Accountable Care Organization?
It was at that very meeting. It was a great story. So Glenn Hackbarth, who's was then the chair of the Medicare Payment Association, said, "Dr. Fisher, you're a smart man, but that's a terrible name."
Okay.
And he said, "Why don't you call them accountable organizations?"
Okay.
And I said, Chairman Hackbarth, I think that's a great idea, but I think it should be care in the middle. Accountable care organizations.
You just inserted it in the middle.
And we had actually used that term at Dartmouth to talk about what we were trying to envision. And I hadn't mentioned it, but he came up with that term. And the funniest part of the story is that the paper was already accepted for publication at Health Affairs in galleys, so it's ready to go to press. But it was called the Extended Hospital Medical Staff. And so
you stopped the presses.
I stopped the presses. The editor gave me a chance to change the title to something about accountable care organizations, and also gave me a footnote that gave Glenn Hackbarth credit for the name. Joint credit that we took. The name came up as we were talking at the hearing. It's the first footnote in the paper. 2 years later, the name was widely accepted. Hackbarth took credit for it. MedPAC became a supporter of the idea.
Okay.
It was a very interesting moment. And then, then it was 3 or 4 more years to get it into a shape that Congress would endorse it, and it was included in the Affordable Care Act.
So we got these ACOs, or adopted by MedPAC. They become part of the Affordable Care Act, which is what, 2010?
10, passed in 10, I think.
Yeah, I think we just celebrated 15 years, or some people probably didn't celebrate it, but it's 15 years.
Yeah. So
we've had the concept of accountable care organizations for 15 years effectively. How effective have they been at reducing variation and cost?
Well, if you read the Congressional Budget Office, or you look at Mike Chertow and his work, they would say that they do save money.
Okay.
For the populations that are enrolled in them, and actually, they're great examples of how effective they can be. With the most recent example I know of, is for their 800,000 ACO enrollees, saved 20 to 30% in their first year of operation, over their first few years of operation. Okay. So real savings. The paradox, and the thing that is a little hard to grapple with, is, well, if they've saved money, why haven't we seen that reflected in the growth in healthcare spending? And 53% of Medicare beneficiaries are now in an ACO. Amazing.
Okay.
In the fee-for-service, Medicare Advantages is about half of Medicare, and some of them are using ACOs to contract with their provider groups. But we're still only, so this is really what sort of sent me back to the drawing board about 5 years ago. What am I missing? What am I not understanding here? And I think there are a couple of pieces that contribute to why we're seeing limited success. First, they're not very prevalent yet. So for most organizations, it's a small share of their revenue. That's certainly true for physicians. It's nowhere near, I think it's well under half for most physicians. So it's not covering everyone. So they still are under fee-for-service for everybody else. So some of the financial incentives for ACOs, the way hospitals who are trying to maximize their revenue, which they all are, they can use ACOs to try to keep their sicker patients out of the hospital.
Okay.
And then you were running a hospital. What do you do with those empty beds in your hospital when you've got a bunch of surgeons sitting around?
Yeah, you can't have idle surgeons. It's a very expensive resource to have sitting idle.
So the reason you like these ACOs isn't because you're reducing costs for your community. You're maybe making care better for those patients and keeping them out of the hospital, which is good. Yeah. But you then fill your beds with with commercial patients who, by the way, in most markets, pay lots more than Medicare patients do. So the dynamics in the system are one where, an effort to squeeze in one place effectively, with good quality results. The outcomes are better for health. The quality measures are better for patients in ACOs than others, but you're leaving unrestricted the rest of the fee-for-service system. So that's one reason why healthcare costs didn't. I didn't see the deflection in it. None of us saw the deflection in the curve, even while some populations are getting better care and lower costs. So that's really the first problem, is what I've come to refer to, and others have as well, or they've noticed it for a long time, the balloon problem. If you squeeze in one place in the American healthcare system, you can have healthcare costs pop out someplace else, and it's not hard to look for those other examples. So what have insurance companies done to try to keep their premiums down?
I think that's a whole other conversation. The MLRs, medical loss ratios, were an interesting attribute of the ACAs.
Limit medical loss ratios. What else have we seen become absolutely the predominant form of health insurance in the United States?
Medicare Advantage.
High deductible health plans.
Okay.
On the commercial side. High deductible health plans. Almost all of us are in them, all of us who can afford them.
So that's just high deductibles, and higher annual deductible.
Yep. And higher copayments. So you have to spend the first $6,000.
Why is that bad?
It's not. First of all, it's bad for several reasons. It's terrible.
It's shifting the risk threshold, right?
It shifts expenses to the people, right? To people to our insured, the insured population. They have not reduced costs at all. They've shifted costs from insurers and employers to employees.
Okay.
So that's part of the balloon. They get to keep the premiums down by shifting the cost spending onto consumers. So that's another way that the balloon is shifted dramatically.
Non-scientifically, like when I'm walking around rural America, which I live in rural America, I see a lot more people enthusiastic about these programs.
Because?
I think they see it as again, there's no science behind what I'm going to tell you, but just some comments have been, they like the choice. They like almost like a restoration of their ability to choose healthcare and have a direct ability to shop for healthcare.
Well, I mean, I think choice is absolutely important. We talked about shared decision making.
Yeah.
It's fundamental there. I think choice of insurance plans is fundamental. Choice of providers, wise. We should be choosing providers. The question of whether high deductible health plans are the best way to make that happen. Mm-hmm. If your healthcare were free, you still would have to choose, right? You still have to choose which provider to go to. You might even have more choice because you wouldn't have this distinction between in-network providers and out-of-network providers. So if I want to go to some fancy place that's not in my network, it's actually much harder for me to choose. And there are good reasons to think that the out-of-network places are going to be more expensive. The last thing about high deductible health plans, and then we should go on, we continue on, is that they don't help people make better decisions. We know that they make bad decisions. Consumers make bad decisions using them.
Yeah.
They avoid necessary care, before they hit their deductible. And then afterwards, it's like, why not get all this stuff done now? I've hit my deductible. I've hit my deductible.
Yeah.
So they're terrible.
If you were presented with the same situation you were in the early 2000s, sitting in that same room, coming up with the name for ACOs, getting buy-in from MedPAC, how would you be pitching the idea differently?
First, and I did this with Mark, all of that work was jointly with Mark McClellan. So I was not I may have come up with the name with Glenn Hackbarth and done some of the math underlying documenting how doctors are in natural groups. But the most important thing I did was realize I need help. This is a cool problem. There's this guy, Mark McClellan, who I've heard of.
Who's that?
He used to run Medicare, used to run the Food and Drug Administration. Let me see if he'll talk to me. And, I was off to a cross-country ski race. We managed the phone call from somewhere way begone and, somewhere in Lake Wobegon, on the way to Northern Lakes. And he said, oh, that's a good idea. Let's see if we can work on that. He'd had a program just for large medical groups that was quite similar.
Okay.
And so we both decided and spent 3 years trying to get it into the law. So if I'd had my choice and we had our choice, we had already thought it was important for everybody to be in these systems. All payers should be participating.
Okay.
And, so the answer still is all payers should participate in this.
How would that change the efficacy of these programs?
Then two things happen. One is essentially the medical group who's responsible, the physicians, are now under capitation, essentially capitation.
Sure.
And so first they have a much more powerful incentive to save money on everybody. Mm-hmm. So they're not going to play this balloon game of, let's pay arbitrage we're going to maximize our profits by keeping these people out of the hospital and doing more stuff to these people. So uniform incentives. And that lets you start to develop models of care that apply to all of your patients, which allows you to innovate. You can't afford to develop cool new systems for 25% of your patients or 50% of your patients. It's got to be the vast majority of your patients for you to say, let's hire our own behavioral health specialists, et cetera, et cetera. And that's been well shown. So it has to be an all-payer model for these things to succeed. And that's been the policy of the Biden administration. We'll hope. I think there's strong interest, I understand, from the Trump administration.
So we've talked a bit about how effective ACOs were at the managing costs and bending the cost curve. What did they do in the quality space?
Oh, they improved quality pretty substantially. Not hugely. I mean, the real challenge on the quality side here is that we are still not even doing a great job on the basics of taking care of people with chronic illness, either diagnosing them or treating them effectively. Half of patients with blood pressure are not diagnosed, and I think it's 20 to 40% of patients with high blood pressure are not adequately treated, depending upon which threshold you use, the 140 over 90 or the 130 over 80. But there's hope there, because integrated delivery systems that are really, or medical groups that are really paying attention to applying what we've learned from the science of improvement, modern improvement work launched by the Institute for Healthcare Improvement and Brent James at Intermountain, organizations that take that stuff seriously can hit 90% scores on diagnosis and correct treatment of people with chronic illness. We're just not doing it everywhere else in the system.
Yeah.
And I think the hopeful piece is that when you move to global payment combined with a commitment to quality, where your underlying strategy is about delivering excellent care, you can both reduce the costs dramatically and in large part by improving health and doing a better job of treating people.
Where you're seeing that, the few pockets in country, are you seeing financial sustainability?
Yeah, no, yes and no, right? So Intermountain Healthcare is a really important case study of what's possible. I mean, they had as a system adopted since the founding of the system a commitment to quality. Brent James came there sometime in the late 80s, I think 1988. And then they built a whole organization around delivering outstanding care, applying Deming's lessons of quality improvement from business. And then they got really serious about it in the early 2010s and decided that their strategy was going to be to both adopt quality as a strategy across the organization and try to keep healthcare costs for their community at the Consumer Price Index plus 1%.
Okay.
A target they hit, which is well below where anyone else was. The reason they were able to pull it off is because they had a health plan called Select Health, which they owned. Mm-hmm. And they achieved enough savings in Select Health to subsidize all the free riders in Medicare and other who were getting, having the utilization saved by having the decreased utilization that is associated with better quality. And so they Brent James and I think it's Greg Paulson wrote a Harvard Business Review article where they asserted, we achieved in 3 years 18% savings on our per capita costs by taking cost out of the system.
Yeah.
And we could achieve 50% savings in the United States if we moved to capitation for everybody.
Okay.
And we would have much better quality.
Let's do it.
Yeah, exactly.
How do we get there?
Leaders. No, there are two ways to get there, I think. One is we have to change the payment system, right? We need to all move to these models where the incentives to the organization are to keep people healthy, are to improve their care, are to make sure you're not harming people, or you make sure that your care is extraordinarily safe. We know what IHI and the patient safety movement has done. It's possible. We just do not have systems that have adopted this systematically. And I've been prowling around to find it's certainly fewer than 10 systems in the world, and you'd put Yun Shipping, you'd put Nuka South Central, you'd put Intermountain for a period. They lost it. Maybe they'll come back now. You put Virginia Mason trying to do this. You'd put Kaiser Permanente. You'd put Cincinnati Children's, but I don't know the extent to which they've really focused on affordability for their community. So it's possible, but it takes a board that's committed to it and leadership that wants to pursue this as a goal.
How do you, in your seat as an academic, influence maybe creating more leaders?
Well, I teach a course in population health, here at Dartmouth, and this is what we've walked through is a fair bit of what I'll teach them, and we'll come to the more political challenges, I'm sure. But I think we need leaders to understand that clarity of purpose is essential, and serving your community has to be part of that. How do you focus the work on the best possible care for your patients while serving the public good, which is cheaper, better care for our communities? And if that becomes your leadership mantra, then I think we start to be able to change this. But you can't do it by yourself, and that's where the policy, advocacy for policy on the part of by leaders who want to move in the right direction becomes really important. And you have to have policies that start to make it possible.
Why aren't we seeing more health systems, delivery systems, policymakers rally around what appears to be an obvious approach?
First, change is hard. It's so much easier in healthcare, especially as you get to be a larger system, to grow your revenues, and then you can, because they've been trained how to do that, all these leaders. Secondly, you can become a monopoly, and then you can raise your prices. So it's not, if you grew up in what we now increasingly recognize as a financialized system across the economy, but especially in healthcare, where your performance is measured only on financial metrics, which is judged both in how big your revenues are. You want to be a bigger system. You've run hospitals, growth is sort of the mantra of health systems.
Yeah.
And, so growth is where you're going, and maybe some cost cutting, but that's really hard to do. You might have to lay people off or think about how you're going to reorganize your administrative system.
Yeah.
And so the easy way is monopoly pricing and increasing your volumes, getting another, recruiting some more neurosurgeons to do more neurosurgery because it pays well.
One of the things, and I didn't know who you were in 2012, 13, but one of the things I was trained to do is to look for independent private practice,
mm-hmm.
and to bring them into our employed models,
mm-hmm.
for purposes of being ready for ACOs.
Mm-hmm.
And by 2000,
the ironies.
By 2017, 18, in the markets that my limited experience, my markets, there was so much animosity between the hospital systems and the primary care providers because they felt that we were gobbling them all up.
Yeah, well, you were trying.
How else should we have done that?
Well, I think, and the model that I think we would like hospitals to be focused on their job of delivering the best possible inpatient care, and physician groups to be focused on how to it is physicians, after all, who write the prescriptions, focused on, the goal of keeping people healthy and out of the hospital.
Yeah.
And we know this now about ACOs. Hospital-owned ACOs don't work. They have the incentives to keep the beds full are just too strong to get over. It's the only ones that the Congressional Budget Office has said are successful are either strongly primary care dominated groups,
okay,
or groups that are run by groups that are run by physicians, not run by hospitals.
You've been knee deep in Vermont's medical pricing fiasco. What's the one place that we should be pushing on?
Well, it's a perfect question, because I will say there is no one place. So the answer isn't here's the fix. The answer is, how do we build a process, a system that can be maintained over the years it's going to take to get us to reform our healthcare system so that it becomes high performing for everybody, so that we have better health, better care, and lower costs for everyone. And I think states are the right place to do it. It is terribly ironic and tragic that right now Vermont has suddenly become the most expensive place to get health insurance in the country for employers and for individuals. Wow. We used to be kind of below average. Health insurance premiums in Vermont are now, 100%. They're now double what they are in the rest of the country, and we're higher than Alaska, where supplies turn out to be more expensive. It's outrageous. So it is a canary in the coal mine for the problems. I would usually refer to private equity as the problem, but we sort of have the epicenter of, I think, multiple factors contributing. First, we've had a hospital that became part of a hospital network where the new leader came in who really wanted to grow his network, and happened to be a powerful monopoly in the whole northwest section of Vermont, covering 40% of the state. They provide 60% of the hospital care in Vermont, in that network. And they extended to New York now. So they wanted to grow the network and hire more people, become more of an academic medical center. They've got an associated medical school. And they just went on a growth spurt. They have monopoly pricing power as well. So they just started to set prices that were, a 12 to 15% increase in prices each year. We have, in Vermont, amazingly, one of the most, powerful state agencies in terms of its regulatory authority that it's been granted in the country. But for many years, they really were just approving hospital budgets as they came forward.
Okay.
That happens in many regulatory agencies. They get captured by the agency, or the people are sympathetic, and no one wants to turn down a budget request from a hospital if you can. But it was only 3 years ago that a new chair came in. I think it was 22. Owen Foster came in and, said, well, hold it, what's going on here? Let's start to slow this down. And it's been a nasty fight, but the consequences of UVM's irresponsible behavior, UVM Medical Network's irresponsible behavior on pricing, has been that we now have a financially nearly insolvent major insurance company. Blue Cross Blue Shield could go belly up. We've savaged primary care practices because the cost of health insurance is one of their major costs. Mm-hmm. And so they can't afford to hire the people they need. So practices are having a hard time. And that starts to be a vicious cycle, right? When you can't get people into primary care, they go to the hospital. They go to the emergency room. So I think there is an answer in this crisis, which is you need a strong state agency that can tightly regulate hospitals because they want to grow and you want them to deliver great care, and you would like them, we actually would all like them, to shrink a bit.
Yeah.
So the recommendations that the four of us came up with who wrote this paper were, one, you need a strong state agency that understands and tracks all the costs in the system, identifies the drivers of unnecessary costs, and then has the tools that allows them to do that.
Would that be unique in Vermont? Or
no, there are a bunch of there are a whole bunch of states who are starting to set statewide spending targets.
Sure.
Keep their, and then start to control those costs when they can.
California went
voluntarily.
there.
California's starting to do it. Massachusetts has had it for a while. Rhode Island, actually, does Rhode Island have a total cost of care target? I can't remember right now. But there are a bunch of states, 10 or more states. And so set the target and then have a strong agency that can say, how do we get there?
Why can't we just use the existing antitrust laws?
Because you can't break these things up. You should use them to try to keep new monopolies from forming.
But once they're formed, it's harder.
It's very hard to break things up. And hospitals, I hope that happens. It would be good to have more competing hospitals. But I think the more likely way that competition could play out effectively is through competing, primary care focused medical groups, or even primary care groups where patients could choose, even in Vermont, where there's a hospital in most markets, but there's only one. So you regulate the hospital so that it makes sure it's financially solvent. And then you have thriving primary care practices.
Some states do this for electrical utilities.
Yeah, no, every state, wonderful, every single state and the District of Columbia regulates utilities, have had public utility commissions since World War II because they know that utilities are rife with market failure.
Should we do the same thing in healthcare?
Yes, absolutely. We just had a colleague and I just had a piece in U.S. News and World Report saying It's time to think about the Public Utility Commission model for healthcare.
You recently wrote a paper on the financialization of healthcare. And even in this podcast series, we've seen quite a few conversations around private equity and other sources of the focus on financialization. And even one guest talked about how even the nonprofits from 30 years ago to today have shifted from long horizon strategic planning to really the quarterly cycle that we were seeing in investment-backed enterprises. So tell us about that research and what you wrote about.
Well, I mean, I think it's, it's the most important change that's happened in American policy and politics.
Not even just healthcare.
No, it's across the board. Wonderful book by Martin Wolf called the Crisis of Democratic Capitalism looks back, to 1980 and the times, and describes that period as when American corporations became increasingly financialized, with increasing attention on, stock values as the way you measure the value of a company.
Okay.
Banking becoming involved in everything. Everything is turned, the mortgage that used to be held by your local bank,
credit union,
your local credit union is now financialized and sold to a bunch of people.
Sure.
So, hospitals, their board members are made up of people who, many of whom are chief financial officers or bankers, or all of whom think that lending money and making money is the way to organize this system. So, and the problem is that it's been aligned with this other, the political side of it, which we've just seen play out in this country, which is as those who are powerful gain more power, they want more power. And they use their influence to change the rules in their favor. So this is played out exactly over these 50 years, nearly 50 years, 45 years. And, the share of wealth that's now concentrated is much more concentrated in the United States than anywhere else in the world. Share of income going to the top 1%, much more concentrated than anywhere else. And all of this is a consequence of not only the financial, it's contributing, it's a vicious cycle of things going, contributing to further financialization where powerful interests have influenced and changed the rules. And you see how this played out. Thomas Philippon has written a wonderful book, How America Gave Up on Markets gave up on free markets is the subtitle. And it walks exactly through the economic consequences of lack of competition and monopoly and development of monopolies, but how they've taken over the regulatory systems to make sure that things are in their benefit. And it now takes longer to start a new company in the United States than it does in Europe. We are becoming a much less competitive and therefore much less productive and much less healthy country.
How do we get back to free markets?
So we need much stronger oversight of markets.
So oversights could actually create the opportunities to get the pathways back to free markets.
You could create, with good legislation, we could make it, reduce the regulatory burden on new businesses entering the markets.
Okay.
We could set up structures in healthcare that allowed competition, better competition at the health plan level.
Yeah.
California is a great example under their exchange where they required the benefits all to be similar. And so patients could choose which one was cheaper, and they had quality measures so you could choose the cheapest plan, not being confused that the cheapness might be because of some funny thing with benefits.
Yeah.
But, no, it's the delivery. It's how they're delivering care. We ought to adopt that for all health plans. Ought to be required to have the same simple, let's just keep it to 4 flavors. Affordable Care Act had a pretty good idea there.
Yeah.
Choose your flavor, and then within those flavors, choose the organization that you want to get your care from.
You sit in academic and policy circles, and you're in some pretty interesting conversations, I imagine. Maybe it's really boring, I don't know. But which single question in those meetings stirs up the most controversy currently in your circles?
Controversy. I think it's I think it's around this question of competition and choice. And because I just don't think we're coming to grips with where it's reasonable to have choice for people.
Okay.
And the free marketeers think healthcare is like other commodities. You can choose your doctor, you can choose your treatment, you can choose, and I know that's not right. I think once you're sick, you're not going to make wise choices. You're going to listen to whoever's nearest to you. Yeah. Once you're heading to the ICU, you're not going to ask, which doctor should I see? You want to be in a great system. So the places to make choices are, who should my primary care physician be? What should the organization that's going to take care of me and then have great data about what those are. And then when you want to choose a specific treatment, when you can choose, you should know, what are the outcomes of that treatment? How good is it? How cheap? Can they do it both with excellent outcomes and low cost? I want to go there. So, I laid all this out in an article that perhaps you can put on the landing page for this thing because I think if we think about what's needed as a single system, multiple payers in a single system, we could solve this all.
Should we go multiple payers or single payer?
That's a political choice. It's going to be tough in the United States. Some places have done single payer beautifully.
But maybe you're saying if we're going to go multiple, then let's make that competitive.
Well, and they have to all be playing by the same rules. So I just laid out the insurance. You have to great measures of quality and transparency, and you have to structure it so that the choices can be made. Informed choices can be made by consumers because there are patients to the extent possible. I think integrated delivery systems make the most sense. But I can imagine that competing primary care group, a great primary care group and with an associated insurance company that lets you go where you might choose could work too.
From where you sit today, what is the single most powerful leverage point that hospital administrators have and health policymakers have, maybe some academics have, to finally make a difference in this system we've been describing today?
Well, I remember, when I had come up with the idea that became ACOs.
Okay.
I'd done the academic research.
Yeah.
And I'm sitting in a conference room at Harvard, and this guy, Peter Senge, is at the front of the conference room. And there are a couple hundred people there. And I'm sitting in the back. I'm not paying attention as much as I probably should have. But I suddenly hear Peter say, "So, Elliot, stand up.
Okay.
What do you stand for?" He knew me because I'd written some, the healthcare stuff I'd done. But that was quite a question. It ended up being the thing that prompted me to call Mark McClellan and see if together we might work on this idea of getting ACOs into legislation.
What do you stand for?
I wanted to make care better for the American public. I didn't want to just have my work sit on the shelf. I guess the publications got me well known. That wasn't what I wanted. I remember I've been driving that ambulance.
Yeah.
And so that's what made me decide to really devote 3 years, a lot of my time, not writing many more papers, focusing on trying to do the policy side. So the question, back to your question of what's the point of leverage? I think the point of leverage is the question of why are we here?
Yeah.
What's your purpose? What do you stand for?
How does the next generation of academics and administrators help that Elliot sitting in the ambulance accomplish what he set out to do?
I think, I really think it comes back to what is our purpose in this world?
Yeah.
And if we all thought more carefully about that question, I think we'd all realize that, and we know this from all sorts of research, that purpose is what gives, purpose and meaning is what leads to the greatest satisfaction and of a life well lived or a job well done. And I think linking our work to the purpose of serving the public good. After all, why did we come to healthcare? Why are we working in this particular field where our purpose should be to reduce suffering? And healthcare right now in America is causing terrible suffering because of the financial burden it imposes on people. When you look at the financial burden on individuals, 74% of Americans are worried about healthcare costs. 74%. The burden of medical debt is riding. The suffering that people have fearing future healthcare costs is just terrible. So many people are harmed by healthcare that they're probably too numerous to count when you look at the complications that are from avoidable complications. So we came to this work to relieve suffering, to improve health. And I think we can do it if we continue to ask ourselves that question. Why are you here? Why are we here?
What do you stand for?
What do you stand for?
Our last guest didn't know who you were, but I asked them to give me a question to ask the next guest. And their question was, how do we make empathy and compassion the pathway to sustainability in healthcare?
I think it's exactly I'd asked exactly the same question.
Yeah.
What do you stand for? What do you stand for? Why are you here? This question about how can we make this this endeavor that is healthcare more about compassion and empathy. And that's probably trying to see things as they are more of the time. Spending time listening to people about what their experience is in healthcare.
As we wrap this up, if you and I are talking in 5 years, having the same follow-up conversation, what is the single metric that we would look to know that we've been successful in the last 5 years at moving the needle?
I'd never want one measure. And I'll tell you why.
You can give me multiples.
I'd want to know that healthcare has become more affordable for every American. And that we've moved that needle on worry about the cost of healthcare. I'd want to know that everyone feels respected and valued when they're spending any time in a healthcare system. And that's for the people who work in the system and the people who are receiving care in the system. And I'd want to know that people's health is improving. So we're reducing the burden of illness. We're keeping people healthier. The life expectancy is improving, and we can do that. And I'd want care to be safe. So there are multiple dimensions, because you have to focus on all of them to get any of them right, I believe.
Dr. Elliott Fisher, thank you for the last 40 years, your research. It is making an impact in this time you've given us today.
Well, thank you. What fun.